And there we have gastrointestinal motility disorders in diabetes. As said that elevated glucose levels is associated with gastroparesis diabeticorum and is found in almost 50% of diabetics. To know more about it, I welcome on stage our speaker for today, Dr. Somenath Mukherjee, who is a consultant gastroenterologist attached to Narayana and CMRI. Along with him, I welcome our chairpersons for today, Dr. Dilip Todi. We all know him. Member, Scientific Affairs and founder member of HDS, and he is the leading gastroenterologist of Howrah. Along with him, I also welcome Dr. Sanjay Basu, who is a consultant gastroenterologist attached to Narayana. I welcome the speaker and the chairpersons on stage.
Dr. Somenath Mukherjee, all of you probably know him. He is a Howrah boy. He was born and bred up in Howrah. He did his MBBS from Medical College and did his MD from PGI EMEA, that is IPGMR Kolkata. His further training was in gastroenterology, was in UK. In and around London he worked for a long time, and he came back about 10 years back, and he is a leading gastroenterologist not only in Calcutta but also in Howrah as well. Somenath.
Good morning, and thank you very much, Dilipda, for those kind words of introduction. Really makes me embarrassed. Thank you very much for inviting me to this forum to talk on a subject which is really not essentially my forte. Some gastroenterologists like me are more based interventionally rather than on the motility disorders, but I will try to make the best out of it, because the issue is rather contentious, as you will see when we go along, and it's rather daunting to follow the talk up with Dr. Gupta with loads of science in between. Yet there is science, but a lot of it is very unclear. Now see, this you all know, diabetes has reached epidemic proportion in both developed and developing countries. The number is likely to increase in the coming years due to aging global population, urbanization, rising prevalence of obesity and sedentary lifestyles. This all of you know much better than me. And diabetes affects virtually every organ system in the body. Duration and severity of the disease may have a direct impact on the organ involvement. Now, the bit we are concerned about is the GI tract. Now, how frequently does it occur? This is a very contentious issue, because if you really looked at it from the scientific point of view, what is the prevalence of GI disorders or GI motility disorders in diabetes? Now see, if you looked at it from a very scientific plane and you teased out the confounding variables, which is obesity, hyperlipidemia and other things associated with diabetes, the real prevalence could actually be very low. Now this business of up to 76% with diabetes have symptoms of altered motility comes from a single study in US where they actually analyzed retrospectively 136 patients with diabetes and went through a questionnaire with them and found they had some sort of dysfunction. So the symptoms of altered motility, we will basically deal with esophageal motor dysfunction, gastric motor dysfunction, and intestinal motor dysfunction. But I have to say that the prevalence is not actually clear, and it's not based on very hard data. So, what are the esophageal complications that usually happen? Esophageal musculature and sphincter is innervated by the autonomic nerves. And in diabetes, you have got an autonomic neuropathy, and there is structural remodeling of the musculature. Now, which creates abnormal peristalsis, spontaneous contractions, and decreased LES tone. All this is very simplistic. It sounds very simplistic and very linear, but it isn't so, because if you really looked at it in the scientific plane, the symptoms of esophageal dysmotility that you have in diabetic patients will not always have a linear correlation with their motility and manometry studies when you wanted to do it. There lies the fallacy of the whole thing. Now, what are the typical symptoms? You all come across it more frequently. Pyrosis, dysphagia, chest pain. Now, what is the prevalence of esophageal dysmotility in these patients? The prevalence of esophageal dysmotility has been reported to be as high as 63%. No difference between type 1 and type 2 diabetes. There is a strong association with retinopathy. Now, again, the actual prevalence in terms of symptoms is about 50%. And if you actually endoscope these people, the prevalence of erosive esophagitis is about 40%. And you would be surprised the amount of people who get symptoms lies somewhere in between. So again, there is no linear correlation between dysmotility, symptoms, and what you find in endoscopy. The prevalence of gastroesophageal reflux symptoms in diabetes could be as high as 41%, and erosive esophagitis was more frequent in diabetic patients with neuropathy. This is an interesting observation which I came across once I started reading it. I didn't know about it. Now, how do you diagnose esophagitis? I would not say that you do tests for it, because we all diagnose gastroesophageal reflux clinically. You treat them, and which patients would you do endoscopy in? Basically, you would endoscope only those people who still have continuing symptoms despite treatment or have one of the alarm features. Now, how would you grade the alarm features? All of you are aware. It's weight loss, vomiting, dysphagia, and hematemesis, or a symptom like that. And where would you do a pH monitoring in these people? Basically, somebody who is needing continuing PPIs, who you have got a normal endoscopy and has got chest pain, there you do a pH monitoring. And this is what even the American Gastroenterology Society promotes even in their setting. So I don't think we should be asking for a pH monitoring unnecessarily. And same goes with manometry. In somebody who has got persistent symptoms, you have got a normal looking endoscopy and is on high dose PPI, you are better off asking for a manometry. pH capsule, it really hasn't taken off. High resolution manometry is the standard nowadays. No, we don't do this old-fashioned catheter business anymore. And the impedance manometry only helps in people where you think have got a non-acid reflux. Now, when you looked at the manometry abnormalities, anything and everything can happen. You would like to think that it is only reduced LES pressure and peristaltic contractions, but that is not the case. They can have increased number of spontaneous and repetitive contractions, reduced amplitude of pharyngeal and esophageal contraction, and increased duration of peristaltic contraction, and multi-peaked contractions. Whether they get symptoms appropriate to that, the answer is no. So they get a multitude of manometry abnormalities, but there is very poor correlation with symptoms. Now, management. Better glycemic control may improve esophageal dysmotility and reflux. Management of reflux involves prokinetic and proton pump inhibitors. I mean, first of all, we have to grade the reflux according to their clinical severity. And it's a very simple grading. How many times do they reflux in a week? If they reflux greater than 2 times in a week, that is considered to be a moderately severe reflux. If they are less than 2 times a week, then it is mild reflux. What is the treatment? You try to modify their diet and lifestyle. Then again, when you look back at the scientific data, Whether diet and lifestyle has got a big linear correlation with the symptoms or the management, it has never been validated. But we all give them a diet and lifestyle advice. But if you looked at the data, it has never been validated. Now, what is the approach to treatment? The step-up approach regarding acid suppressant will work in the mild ones where you have a low incidence of reflux, like less than 2 times a week. You start with a H2 blocker and then step up your therapy incrementally according to how much PPI you need. In people who have got reflux more than 2 times a week, you are better off starting with a proton pump inhibitor. These are all coming from American Gastroenterology Association recommendations. Now, the contentious issue is, when do you stop? It is really not that contentious, because for a new patient with reflux, you start them on a PPI, you continue for 8 weeks. If they are relieved, you stop it. If they get their symptoms back less than 3 months from your stopping, you know that they need to be on long-term PPI. And if they are refluxing greater than 3 months, you again treat them with an 8-week course and see whether that would change things after you stop. If you are struggling still, you can add a prokinetic. If you are convinced that it is a high volume reflux and you are going to make a difference, you can add a prokinetic. The important thing is, which prokinetic is better than the other? There is no head-to-head study. Which PPI is better than the other? There is no head-to-head study. In the scientific data is very much lacking in terms of one being better than the other. Absolutely, in very absolute terms. If you looked up the AGA guidelines, you will find the same. Drink fluids immediately after taking medication to avoid pill-induced esophagitis. I thought that is a very sensible advice. Now, esophageal ones are pretty home and dry, I think. I mean, you do certain things. If they don't work, you step up therapy. The contentious issue is gastroparesis. Chronic disorder of gastric motility characterized by delayed emptying in the absence of a mechanical obstruction. So you have to prove that there was no mechanical obstruction. So if you come across a patient like that with nausea, vomiting, early satiety, bloating, postprandial fullness, abdominal pain, weight loss, dehydration, difficult glycemic control, I think you really have to endoscope it, because if you have to tell that this is a gastroparesis, you have to exclude a mechanical obstruction. Now, when one looked at the causes for gastroparesis across the board, diabetes is a significant chunk, but idiopathic is a big one. So we have to temper our thoughts accordingly. Despite all the search of neurological disease, collagen vascular disease and everything, you would be faced with a big chunk of idiopathic gastroparesis, most difficult to manage. Now, approximately 30 to 50% of diabetics are reported to have some sort of gastric emptying delay. Then again, this is coming from the motility studies. They are not necessarily correlated with actual symptoms of gastroparesis that the patient experiences. Women have a much higher prevalence of gastroparesis than men for reasons not known yet. What is the mechanism of delayed gastric emptying? Actually, if you looked at the data, across the board, if you looked at all diabetics, they can have everything. They can have a normal gastric emptying, they can have an increased gastric emptying, and they can have a delayed gastric emptying. So it is not linear. So what are the mechanisms? Altered gastric electrical activity, decreased fundus tone, these are all postulates, decreased antral contraction amplitude and frequency, impaired antroduodenal coordination, increased postprandial frequency of isolated pyloric pressure waves, and decreased duodenal contraction and amplitude and frequency. Small intestinal dysmotility. But the main thing is altered visceral perception, because when you did a when you did a motility study on these people, you could be having all of those except the last one, and they still would not be having symptoms. But if they had the last one, they would be having more of symptoms. Now, correlation with the blood sugar level, gastric contractions are nearly absent at blood glucose level of 250 milligram per deciliter. These are scientific data. Whether it has got correlation with symptoms is very poor, and markedly reduced at levels which are the standard postprandial levels, 140 and 175. Now, as I said, endoscopy is pretty important in these cases because you have to exclude a mechanical obstruction. Would you do a scintigraphy for these people? The answer is probably no. If you ask me, the answer is no, and that is the answer actually from the AGA as well. Because there is a poor correlation. But just for our scientific knowledge, yes, you could do a scintigraphy, and if there is greater than 10% of your food still left after 4 hours, you can diagnose this as gastroparesis. Would you do an electrogastrogram? Probably not. MRI? Probably not. But these are things which are available for scientific research. So what would you do on a suspected diabetic gastropathy? You do a history and physical examination, do the normal biochemistries and an abdominal X-ray. You do an upper GI endoscopy. If there is mechanical obstruction, fine. If there is no obstruction, then you proceed for a scintigraphy. If they are abnormal, you give prokinetics, antiemetics, and dietary modification. Now, I would say that if there is no obstruction, most of us in real life would go on to the prokinetics. Again, moving from esophagus to stomach, in the same patient, you could be having a delayed gastric emptying, but you could have a normal esophageal clearance. So all these motility disorders do not naturally follow their course, as somebody who has got esophageal dysmotility will not necessarily have gastric dysmotility, and the same patient may or may not have a small intestinal dysmotility. So that is an important thing to remember. These are isolated organ systems affected. Why do they do so in a systemic disease? There is no clear explanation for it. Small intestinal and colorectal dysfunction are common with long-standing diabetes. What do you face? Diabetes-related enteropathy, diarrhea, constipation, fecal incontinence. As I said from the previous prevalence studies, when people looked at the symptoms, the commonest symptom set when in the questionnaire in diabetes is actually constipation. It is not diarrhea. The second symptom is actually abdominal pain. And the third one, pretty low down the line in that case, we would like to think it would be reflux, but it isn't. The third one is actually reflux and dysphagia. And diarrhea actually follows much lower down the line. Now, this is something which was a revelation for me because I thought diabetes are more associated with diarrhea. Constipation alternating with diarrhea is one of the most common symptoms of diabetic enteropathy. Now, why does this happen? The simplistic explanation is autonomic neuropathy and fibrosis of the intestinal muscular layers result in stasis of the intestinal contents. Advanced glycation end product cause damage to the cellular DNA and tissues in diabetes. Small intestinal bacterial overgrowth is an important one. Now, diarrhea is typically painless, may be associated with fecal incontinence. And what perplexes us most is a nocturnal diarrhea. Because if you are a gastroenterologist and if you are looking from the gastroenterology point of view, our alarm symptoms for diarrhea include nocturnal diarrhea. We always are worried about a nocturnal diarrhea because there is a organic cause for it. What are the other causes of diarrhea in diabetes? Pancreatic insufficiency, bile salt malabsorption, steatorrhea, and drugs like metformin. Now, treatment of diarrhea includes symptom relief, as we all do, fluid and electrolyte improvement of nutrition and glycemic control. We would use rifaximin, and antidiarrheal agents, actually loperamide can be used. But one thing we have all got to be careful is, we have to keep the differentials of diarrhea in mind when we are dealing with a diabetic diarrhea. Because these patients, when you looked at them, out of all comers with diabetes, there is about a 4% incidence of celiac disease. There is a significant incidence of pancreatic insufficiency, and microscopic colitis is actually quite high in type 1 and type 2 diabetics. So there is a case for investigating them. They may all not be related to dysmotility. We have to keep in mind the differentials here and try to exclude it when we are not getting anywhere. Constipation, as I said, is the commonest problem, affecting about 60% patients with long-standing diabetes. Severe constipation can lead to megacolon or colonic intestinal pseudo-obstruction. Now, this is a sort of generic slide on constipation, not very much to do with diabetes. The initial bit excludes history and diabetes examination, including the blood glucose level. Then,
hurry up, Somenath.
okay. Then whether it fulfills the Rome criteria, and then you investigate for a colonic transit time. If there is a slow colonic transit time, you usually do your dietary manipulation. If it doesn't work, then you can add one of the prokinetics, which is prucalopride or levetiracetam. Now, fecal incontinence, particularly nocturnal, due to internal and external sphincter dysfunction secondary to autonomic neuropathy. Acute glycemia, hyperglycemia has been shown to inhibit the external anal sphincter and decrease rectal compliance and potentially increase the risk of fecal incontinence. Loperamide may prove useful, but then the most useful thing is biofeedback. But then again, when we want to get biofeedback in the clinical setting, it is not well available outside, I think, one center in this city. So, due to interest of time, I would like to stop there and take questions at this stage, because it's a very contentious issue and there will be lots of...
Any questions from the floor?
Sir, the price question first. One price question. Sir, ask one question and let us see who answers.
What is the commonest symptom that GI motility symptom that you come across in diabetes?
Sir, kindly raise your hand, I'll come up to you.
Diarrhea.
No, diabetic gastropharyngite.
Yes, sir.
Constipation.
Constipation, absolutely right.
Sir, kindly introduce.
I reiterated that.
Just a minute.
Question with you.
Sure.
Yeah, question, yes, you were.
May I? I am Dr. Madan Mohan Haldar, posted at Medical College.
Thank you.
Sir, we have a small token for you.
Thank you, sir, for listening patiently. Thank you.
Questions, yes.
Yeah. Esophageal complication with more advance in diabetic retinopathy. Why it's occur in diabetic retinopathy? Only due to the diabetes?
It is an observation. I don't know the reason. Neither does the
It is the
textbook,
observation only.
neither does the study. I can refer you to the AGA study in 1995, Friedman's paper, but
I
it
suppose
is an observation rather than...
Yeah.
I suppose it just reflects probably the poor diabetic control in them.
Yeah, you could say that, but
Yeah.
then again, why do lot of people with poor diabetic control without retinopathy doesn't get it? There is no explanation to it.
You told that in a reflux, where the secondary reflux 2 times in a week, 2 times in a week. More than 2 times in a week, it might be more serious issue. Patient is on PPI, patient is quite diabetic. When the complications arise more, you added prokinetics. In prokinetics, there are few prokinetics thrice a day and once is once a day, also available in the market. Which one is more superior and how long should continue to reduce the severity of reflux?
In this situation, you are better off with thrice a day.
Thrice a day, not once daily. Okay, thank you, sir.
Thank you. We will.
It is difficult to manage diabetic diarrhea, particularly autonomic neuropathy cases. So apart from rifaximin and loperamide, what is the role of clonidine here?
Clonidine?
Yes.
Yes. Clonidine definitely has got a role, and same with octreotide. But the use of clonidine has been actually not taken off that much due to the reason giving is hypotension. This is what is mentioned in the guidelines. See, clonidine you can use in this situation. It is a very useful drug for your diarrhea, but you have to remember for the same group of patients, they actually are suffering from autonomic neuropathy as well. So you risk the chances of orthostatic hypotension. So actually, American Gastroenterology Association doesn't actually recommend using it at this point in time. But the same cannot be said about octreotide. If you are not getting any joy with your diabetic diarrheas, doing the usual things, octreotide subcut TDS is very much recommended, and it helps in a proportion of patients. Dr. Shah will tell you that in a bit, and maybe Dr. Tori will be able to highlight that about octreotide. And but for me, I think the most important thing when you are not getting any joy with a diabetic diarrhea, rather than going down the pharmacology path, questioning oneself about an alternate diagnosis, i.e. whether the patient has got celiac, i.e. whether the patient has got microscopic colitis or pancreatic insufficiency, that would be high up on my mind.
Now, with reference to your diarrhea, particularly type 1, celiac disease is definitely a consideration. And for that, we advise usually TTG or anti-endomysial antibodies also for routine checkup of diarrhea in type 1. So I think that can help us.
Well, sir, I agree with you. We do TTGs in these patients. TTG is the one you should be doing, not anti-endomysial, because as you know, a proportion of these people will be IgA deficient, so you may get a false negative of anti-endomysial antibody. But then TTG is a very good screening test, but it doesn't exclude your celiac completely. And the problem with our setting is all this business of 4% incidence of celiac in type 1 comes from Western data. The data is coming through in India at this point in time, which shows that celiac is not such a rare problem. And if you looked at the diagnostic criteria for celiac as proposed by Govind Mukherjee from AIMS, you really have to do a duodenal biopsy in these people.
No, pediatric endocrinologist. Actually, when they see these patients, they actually advise this routinely, in addition to thyroid, TSH also.
No, true, but it doesn't exclude celiac completely.
Number two, with reference to diabetic gastroparesis, the problem starts when blood glucose, to control the blood glucose.
Yes.
Some of the drugs may not be quite good, as for example, SGLT2 inhibitors. There may be some problems with diabetic gastroparesis. And number two, about insulin, it should be also very short-acting insulin, and to be given after the patient food. Otherwise, there is some mismatch.
Very important point, sir. Incretin-based therapies and SGLT inhibitors are the important ones which actually may affect your gastroparesis. So those are the ones which should be taken off the drug.
Thank you very much, Dr. Mukherjee,
Yes,
for
sir.
your nice elaboration.
By Buddha.
May I know one thing, that how one can differentiate IBS and sometimes with gastroparesis?
Well, sir, gastroparesis, as I showed you, the symptoms are quite different, aren't they? I mean, if you looked at IBS from the Rome 4 criteria, you got to have a change in frequency of your bowel habit, and you really need to see that whether their defecation frequency has increased or changed. And the most important part, you cannot diagnose an IBS without abdominal pain if you looked at the Rome 4 criteria. And I don't think all of your gastroparesis patients have abdominal pain. Abdominal pain is fairly low down on the list. So I would not say that that is a diagnostic dilemma at all in me. Because abdominal pain is the cardinal symptom of IBS according to Rome 4 criteria. Whatever stool and whatever functional dysplasias you may have, you cannot diagnose it without abdominal pain.
Sir, very small question, sir. How many patients with diagnosed nocturnal diarrhea due to diabetes you see in a year? I want to know that because I practice diabetes. How many patients you see in a year who is having true nocturnal diarrhea due to diabetes? What is your idea? You may not be having any data. What is your idea?
Well, if you ask me where diabetes is their predominant problem, I would say very little actually, but that may be due to the fact that I am blessed working in 2 hospitals with great endocrinologists who manage these things so effectively that they don't come towards me. And that holds for Dr. Shah in Narayan Hridayalaya and 2 equally bright colleagues in CMRI. That skews the whole data. But on a more scientific plane, the answer is very low. Yes.
Thank you. We'll close the session now.
Thank you.